I'm going to start recording now. Welcome everyone. This is the newly diagnosed prostate cancer webinar with Cancer ABCs. I'm Jan Manwright. I'm the Executive Vice President of Cancer ABCs, and Joel Nowak is here. He's the CEO and co-founder. And this is one of the webinars that we're doing in lieu of the conference that we had planned for March 21st in the Villages, Florida. We're all dealing with coronavirus and pandemic and isolation and social distancing. So webinars are our new normal. So I think we're all adjusting to that. So this is how we're going to help you today. Neither Joel nor I are medical professionals. We will not give you medical advice. However, once you realize, and I realize this as an advocate, all the ways you can help someone without medical, there's really so much that you can do, and that's what we'll be doing to help you understand your own personal cancer, because every cancer is different, help you understand what questions to ask your doctor and research regarding both risk and benefit of treatments, and possibly even risk and benefit of tests, especially now with coronavirus. Just overall help you develop better questions for your doctor and nurses. And this will help you engage in something called shared decision making. If you guys don't know the phrase shared decision making, I want to introduce you to it now. I would write it down. I would keep it close by. It's actually, you could say it's a medical term. It was introduced, I think, in the late 90s or early thousands. And it's just medicine's way of saying that patients share in the decision with the doctor, and the doctor shares in the decisions with the patient. It's just sort of a more official way of saying it. I like it because it's plain English, but I also like it because sometimes the right words and the right language in your doctor's appointment can make a huge difference. So I found that when I was in a doctor's appointment with my husband and we didn't feel like we were connecting, or the doctor wanted to orchestrate everything. The doctor knows much more about medicine and prostate cancer, but we knew much more about my husband. And those two things need to come together. So if I would use the phrase, we'd really like to do shared decision making, because that's a familiar term to medical professionals, sometimes the appointment would just change, and for the better. So I would encourage you to use that phrase, and you might be surprised how effective it can be in changing what can be going on in your conversation in your doctor's appointment. Shared decision making. We've got a couple sponsors today. I want to thank them. CyberKnife, the company Accuray makes CyberKnife. It's a type of radiation that is called hypofractionated, or SBRT. This is one brand. There are different ways of doing it, but this is probably the most researched brand. Exact Sciences used to be Genomic Health, and they make the genomic test Oncotype DX for men who are newly diagnosed, low risk and very low risk. And then Myriad makes the genomic test Prolaris for men who are newly diagnosed. I believe it's low risk and very low risk. There may be some exceptions with favorable intermediate risk, but we can come back to that. So, okay, so here's an opening statement. Every prostate cancer is different, right? So all you need to know is what's yours. Prostate cancer does not equal prostate cancer. And the more science develops and grows, you'll find that the more differences they discover, then they're able to deliver them to you, the patient, and to us, the advocates. One of our jobs is to help you understand them, because medical lingo is like a different language. So it's a great place for the advocates to be, is just help you understand what the experts are saying. It does come from your medical records. You'll see it's your PSA, it's your digital rectal exam, it's your pathology report from your biopsy. Today we'll be using NCCN Guidelines for newly diagnosed prostate cancer. There's a second set by AUA, which is your urologist organization for newly diagnosed prostate cancer. They are almost identical. The differences are really slight, but right now NCCN has some specific recommendations because of coronavirus. So I think we're just going to stick with NCCN, and we're going to show you what that is. So obviously that leads us to the question, what the heck is NCCN? It's the National Comprehensive Cancer Network. Boy, I hope I got that right. Did I get that right, Joel? National Cancer Comprehensive Network? Sorry.
Yes.
Thank you.
Yes.
But here's a picture of what that means. It's these organizations all over the United States. We do have 2 here in Florida. That doesn't mean that they're, the place that you should go personally. They might be. We can come back to that later. But we do have 2 here. But the NCCN has been around for decades, and they are highly respected. They give recommendations for cancer that are really top-notch, well-researched, and by some of our best experts. So that's NCCN. So the other guidelines we talked about were from AUA. So what the heck is AUA? Well, AUA is the American Urological Association that your urologist belongs to. There may be some urologists that are not members, but it's few and far between. So when you're quoting AUA documents or using them in your doctor's appointment, you're using your urologist's own documents. Again, that creates better conversation. There are some documents like these guidelines that are written in plain English, and you can understand that, and that becomes a great talking point. I'm trying to help direct you to research that's more targeted to you personally and your doctor personally. This is a little bit different than just going on Google and typing in prostate cancer, because we all know that's daunting. And one of the most common phrases I get is, I feel like I'm drinking through a fire hose. And it's just not targeted enough. We'd like to hone that down for you and give you some clear direction that will really work for you. These second set of guidelines, not the NCCN, but the AUA guidelines that include ASTRO and ASCO. The other 2 organizations are ASTRO, which your radiation oncologist belongs to, and ASCO, which would be your medical oncologist if you have one. Most men who are newly diagnosed do not have a medical oncologist. There are some exceptions, and there are some places in the country where it's easy to do or very hard to do. But your urologist did your biopsy. Your radiation oncologist would be the doctor that you go to talk about considering radiation for your newly diagnosed prostate cancer. So here's the medical records that will help you find your risk category, and that's where I'm going to take you. So obviously, when they talk about PSA for your diagnosis, keep in mind it's the last PSA before your biopsy. So not the one after, and not the one, a year later, and not the one, 6 months before, right before your biopsy. That's the PSA they use to find your risk category. Your biopsy pathology report is probably your most important medical record. The better you understand a few key things in that, the better you'll understand your cancer. And when it comes to imaging, you don't need the film, really, to try and understand what you have. The truth is, the only one that can read the film well is a radiologist who you probably never meet, but he's one of your doctors. He interprets your imaging for you. But he also issues to your doctor, your urologist, let's say, and for you, a dictated written report. That's what you need. In that dictated written report will be some details that will be helpful to you. You're not going to understand all of it because it is written for a doctor, but that doesn't mean that you cannot understand a few key things that matter to you. You can, and hopefully we can elaborate on that a little bit. So there are 6 risk categories when you're newly diagnosed. So if I can help you to understand which risk category, or if you're not sure, you're in between 2 for some reason, at least that will narrow down your research and help you to understand what you have and what the treatment recommendations are for that cancer. Even the testing recommendations, the imaging recommendations. For example, it's not recommended to do CT scan and bone scan if you are very low risk or low risk. That's both NCCN and AUA. So it's not recommended. For high risk and very high risk, it is. And I think in favorable and unfavorable, it's I have to double check, but I think it's a little bit back and forth, and it could be variable. So let's get right into the risk categories. So I'm going to take you to very low risk and low risk. Okay, so these are men who have T1C clinical stage. What that means in simple terms is a negative DRE, negative digital rectal exam. That is about 75% of newly diagnosed patients. Now, what that means is on digital rectal exam, there was no, number one, nodule, no hardness or induration, number two. If you had neither of those, your digital rectal exam is negative and you are T1C. If the doctor says something about it's enlarged or even asymmetrical is questionable, but enlarged has nothing to do with staging for prostate cancer. That has to do with enlarged prostate, which is different, which is called BPH. So if you have no hardness and no nodule, you are a T1C clinical stage. And that's what this diagram is over on the right. This is from Johns Hopkins. And you can see in the diagram the illustration of what that is. Okay, so grade group 1, that's your Gleason grading. And if you are a Gleason 6, your grade group is 1, as you can see over here on this, this table. PSA less of 10, again, that's a PSA just before biopsy, right? Cancer in 1 to 2 biopsy cores with showing no more than 50% involvement, half the cancer. And then PSA density isn't something you hear about a lot, but I really like it because it's one place that they factor in prostate size. And a prostate can be, I mean, I've had callers that were in their 70s, age 70, who had a 17-gram prostate and a 200-gram prostate. So it's really not age specific, it's person specific. So this is the formula you use to calculate your PSA density. So that's very low risk. As you can see, low risk is similar, but a little bit different.
Jan, could you just
Yep.
explain, Jan, would you just explain why the size of the prostate would matter?
Well, it matters for this PSA density for right now, but for later on,
Right, but why is that, an important thing to know, therefore PSA density being important? In other words, because PSA is going to be reflected even in a normal state, correct?
Actually, that's a great question. I would want to look up the words to explain that better, but I know it has something to do with the fact that, you know, if the prostate's larger, you're going to make more PSA. So a 60-gram prostate probably makes twice the PSA of a 30-gram prostate. So factoring in the prostate size is helpful. Do you have more to elaborate on that, Joel? Otherwise, I would look it
No,
up.
I think that was the point I wanted to expand
Okay.
on. Thank you.
Yeah. I think I'm going to pause for questions just for a minute because we've covered 4 or 5 slides. So if anybody has any questions, you want to type it in the chat box or you want to unmute yourself. We're going to move on to intermediate risk categories next. And if there's no questions, I'll just move on.
I'm gonna let me then, if I could,
Yeah.
add some stuff at this point, if no one else has anything. You talked about medical records and how important they are, and you also mentioned the film and the reports for scans.
Right.
I think that it's still a good practice to get a copy of your scans and the actual film for your
Sure.
medical record, even
Yes.
though you can't read it, because if you ever want to go to another doctor for a second opinion, that doctor is going to want to see not only the report, but they most likely will ask for the film. So if you get the film while you have the scan, it's a lot easier than trying to go back and do this mad dash.
Okay.
So as a good point of practice, it would be to get a copy of the film. You can usually fill out a request actually when you're at the radiologist's appointment doing the scan, and then you put it into your file so that you have it if you ever need it.
Okay, thanks. And in case everyone doesn't know, Joel is a thriver of advanced prostate cancer, but also 4 other cancers. He's dealt with melanoma, kidney cancer, thyroid cancer, and cancer of the appendix. So he knows what he's talking about when he talks about the importance of medical records. So it's really valuable input that you'll honestly not get anywhere else except here. So yes.
May I? A quick one?
Yeah. Hi, Bernard.
The terms unfavorable and favorable, what exactly is that saying in everyday language?
Well, that's
Favorable,
intermediate risk.
favorable for what?
Well, that's intermediate risk. So that was the next slide. So we're going to get to that next.
Okay, okay.
Yeah. Yeah.
Thank you.
Sure. Anyone else? Moving on. Okay, so here's, okay, we did low risk and very low risk. Now we do favorable and unfavorable. In simple terms, Bernard, it means like favorable is better, unfavorable is less good. So they just choose the words favorable and unfavorable. But they've taken the intermediate risk category and split it into two groups now. And wow, I'm having trouble seeing the screen. I got so much stuff over my screen. Hang on.
So I think it also talks, Bernard, to the possibility of the cancer progressing, and moving on. And I think that's probably reflected in that terminology. That would be my guess. I don't know, Jan, what do you think?
It is. In simple terms, the definition is the severity of your cancer. I think that's straight from AUA or NCCN. But obviously that spills over or reflects on everything that you're thinking about. Your risk of recurrence after treatment, your risk of, metastatic disease in general, but
And even your treatment choice.
exactly, your treatment choice. Yeah, and that's
So
because of those things.
So it doesn't mean that if it was unfavorable that you're not going to get anywhere, don't do nothing. Or
Correct.
favorable means like go to treatment, you can get something done about it, right?
All it means is that the PSA and the Gleason score and the number of cores, that were cancerous, put you into a certain category of more severe or less severe cancer.
Okay.
Then from there, after they categorize you, then they rely on trials, research, and data to make guideline treatment recommendations for you.
So Bernard,
Thank you.
you ask
Yes?
you ask a very interesting question, because what I heard you ask is if you have unfavorable or high risk or more severe cancer, does that mean you shouldn't do anything? Did I hear you? Is that
Well,
what you?
yeah, actually, when we go back to language, like Jan was saying earlier in the clinical, that's not a word I would be using in here. It just doesn't appeal to me. Unfavorable, favorable is like do or die. It's,
Nobody
I
wants to
don't
hear
know.
they're unfavorable, but you got to add the word
Right,
intermediate to it, which is middle, right?
right.
So you're not low risk and you're not high risk. You're in the middle.
Mhm.
So it's
So I think what's really important to know that even if you're diagnosed with metastatic disease and the cancer is, throughout your body, there are treatments today. I think you need to understand that will definitely increase or improve the quality of your life and also the longevity of it. We're blessed to have a number of treatments that can do that. So I don't mistake the words favorable or
Right.
unfavorable,
right.
to whether or not you can benefit from treatment and also maintain a quality of life. It's really important. I'm glad you raised that as a question. Thank you.
So Joel,
Welcome.
tell us, are you metastatic? If so, how long? And are you on treatment?
I am metastatic. I have been metastatic for 13 years.
There you go.
I was diagnosed initially 5 years prior to having it reoccur, or finding out that I was metastatic. I continued to do hormone therapy. It's not a topic of this to talk about how I do that, but I am having treatment. I am feel as well and as healthy today as I did when I first found out that I had a reoccurrence. I'm fortunate that way. Again, Jan reflected back that everyone's cancer is different, and not only are our numbers different, but that really goes down to, if you drill it down, to the fact that our cancer is actually a different disease. So I noticed that there are 19 people on the call. 18 people probably have prostate cancer on the call, because I'm assuming Jan doesn't. And there are probably 18 different prostate cancers on this call, because our genetics are different. And I think that we respond differently. And that's why understanding these categories and where you may lie will give you a better understanding of how to have a conversation with your doctor as you make decisions on treatment and what type of treatment. I think that's really what's important. But no, having metastatic prostate cancer does not doom you to die and does not doom you to having a terrible experience. I'm 13 years and my quality of life is excellent, and I am still very much alive.
My husband was, now Joel's metastasis to his lymph nodes. My husband was metastatic to the bone from day one with a PSA that was over 7,000. I got very involved. Before I knew it, I was picking most of his treatments, and he lived for 13 years also. So that's a right off the bat message, just sort of like put any fear in context. We're going to take you there to that understanding. So when you see a word unfavorable, it just means it's just not quite as good as the other middle risk category. It's just like they use big words. You're right. They do that all the time. But it's just not quite as good as this one, but it's still better than high risk. And even then, you know, it's not it doesn't mean that it's lethal. It doesn't mean you're going to lose your life to prostate cancer. Nobody knows that. The way to stay alive is to get a basic understanding of what you have to begin with. And I'm trying to start you out there and then take you from there to the next steps. So, yeah.
So
We
when I
basically
had my
turn prostate cancer into a chronic disease for men who are metastatic as best as we can. So go ahead, Joel.
When I had my reoccurrence, I pushed my doctor, you know, how long do I have to live? Because I was not educated, I had no experience, and I assumed that it was going to kill me. And after pushing the dickens out of him because he didn't want to answer the question because he doesn't know and didn't know, and no doctor knows, he finally said to me, look, in 5 years, I would say that you're probably going to still be a patient of mine, but I can't tell you anything beyond that. That was 13 years ago.
Yeah.
I'm very much still his patient because we work well together. And if I were to ask him that question today and he were to be pushed to giving me an answer, he could give me exactly the same answer and be just as wrong, but just as right.
Part of the reason for that is we cannot measure everything. So we measure what we can. What we're doing here now is measuring what we can from your original diagnosis to give you your starting risk category to help you understand what treatment choice initially probably or probably does not make sense for you. That's all. From there, honestly, moving forward, we can't measure the new developments that are going to happen next year or the year after. We don't know. But we know there's a whole lot of research going on. We can't measure how your overall health or your involvement in your healthcare makes a difference, but involvement in healthcare does. And this is part of being involved in your healthcare, understanding some basics to start out. So that's where we're trying to start from. So don't let unfavorable be anything more than it's a middle category, not quite as good as favorable. Okay? That makes sense? I'll assume that's a yes.
Yeah, I just had to go find my green mute thing on this little phone.
Okay. All right.
Okay, thank you.
Very good. Okay, I'm going to move on to the high risk category. Okay. Again, there's 6 categories. Very low, low, favorable, intermediate, unfavorable, intermediate. That's way too many words. High risk and very high. Okay. So this is usually fewer men, but if you do have a PSA that's over 20, that bumps you out of intermediate risk. And when you get into your Gleason 9s and 10s, and I'm going to sort of just keep going from there, if that's okay. I want to move on to how this reflects now on a treatment choice. So moving over to AUA treatment guidelines. Here now, I want you to show you if you have very low risk or low risk, which we saw up here in this slide, right? Your own urologist organization recommends that active surveillance should be recommended if you have very low risk. Active surveillance should be preferable if you have low risk. So right off the bat, once you understand your own cancer better, you understand what the recommendations are. And I'll start with this one because I still know today that there are some patients who don't get told this. And active surveillance means you're not choosing surgery, you're not choosing radiation, you're working towards deferring it till a time when you may need it. And in the meantime, there's a lot of things you can do. A lot of men change their diet, get healthy, consider other things. So I'll start with that. Anybody have questions on active surveillance? And is anybody here, have you determined that you're either very low risk or low risk, which is, again, this slide? Okay, I'll just keep going. Now, an additional recommendation for very low risk and low risk is that doctors should not add hormone therapy, which is ADT. ADT is abbreviation for androgen deprivation therapy. It's just another word for hormone therapy, because we discovered medicine use a lot of words that we don't use. So, and then you can see, except to reduce the size of the prostate, for brachytherapy, which is radiation seeding. And then it talks about cryotherapy or cryosurgery. Clinicians should inform patients considering focal therapy or HIFU. So, any questions on this slide? I'm just going to move on. And then I want to see if you guys understand your risk category. I think that's really where I'd like to make sure we've left you. So these are the guideline statements from AUA, which is your urologist again, for if you have favorable or unfavorable intermediate risk. And you can see they're different. Clinicians should recommend radical prostatectomy, which is surgery, or radiation. Well, I got to move my screen here. Plus hormone therapy as standard treatment options for patients with intermediate risk localized prostate cancer. Now, this is a recommendation or a guideline, but it's not always definitive, because every patient is different, and that's something, this is for you to discuss with your doctor. But this is where the guidelines take you. And then alternative options, it talks about favorable intermediate risk prostate cancer. You can consider radiation alone, and so on and so forth. So I'm going to stop there. I want to make sure that everyone on this call who is newly diagnosed does have a good understanding of what they think their risk category is. How many people believe that you're low risk or very low risk? You can unmute yourself, I guess. We can try that. How many people believe that you're this? Anyone? You can also type in the chat box. Yeah, hi, Jared.
Jan, can you hear me?
I can, yeah.
Yeah, hi. Yeah, I'm intermediate unfavorable, intermediate. So representative of the last slide you had on.
Yes. So how long ago were you diagnosed, if you don't mind me asking?
It was January 22nd.
Got it. And what is your thought process, and have you started hormone therapy or anything?
I have not. I'm meeting with a radiation oncologist up in Cleveland. And the question that I had, you may have answered with the last slide, which is ADT with radiation. That's what I'm likely to choose.
Okay. So let's talk about that for a minute. Do you know your prostate size, for example?
I do not know the prostate size, but I have that as a question that I want to ask in a phone conversation with the ahead of time with the radiation oncologist.
So do you have a phone conversation before you go to visit?
Well, it's up in the air, because I don't, 90% chance, I've had a phone conversation with this doctor because of some other contacts that I had, but So what his nurses told me is there's a 90% chance that my May 4th appointment is likely to occur as a webinar.
That would be telemedicine. Yeah, and that's because of coronavirus that we're in right now. And there's new recommendations to keep people apart, and they're doing a lot more telemedicine. Do you have Medicare or private insurance, if you don't mind?
Medicare.
Yeah, Joel posted
Medicare.
something on cancerabcs.org that Medicare expanded their coverage of telemedicine during this coronavirus. So it seems likely to me that you'd be covered. But we'd love to help you develop the right questions so that you can get the right answers. Yeah, go ahead, Joel.
Okay.
I was going to say, so these guidelines are guidelines, as Jan has reflected, and there are some modifications in guidelines due to the virus, because generally people are trying to avoid contact and also avoid hospital visits. So it's possible that some of these, recommendations that the docs are going to come up with may be a little modified. They may be trying to stall stuff. So for instance, if you do radiation, there are a couple of options, and this is something you can talk to the doctor. How many visits would they be requiring? They can choose the number of visits, therefore the potential exposures by hypofractionating, by increasing the level of the dosage of the radiation. There's also a possibility the doctor may say, maybe we won't do radiation right away until things get a little better, a little safer, and we'll just do hormone therapy. These are the possibilities that we're seeing doctors modifying. So that's something you may want to ask the doctor, given the risks of transmission of the virus and exposures to the facilities, to the hospitals, to traveling. Are there things that we should be talking about that might be a little different?
Right. That's actually in the new guidelines from
Thank you.
NCCN. Yeah, NCCN because of COVID. So yeah. Asking him your prostate size is certainly one question, because now the guidelines for the size of prostate that I would ask him, this would be my second question. What size prostate is too large for the type of radiation that you offer? What size prostate is too large? Because
Okay, thank you.
Yeah, the hormone therapy will reduce the size of your prostate, although it can take some time. And I'll be honest, I've seen situations where they give a man hormone therapy to reduce the size of his prostate, but they don't go back in and remeasure to make sure it's reduced enough. So if your prostate's 100 grams or something really large, that's a really important question. And the issue there is that the larger the prostate, if you think about this, it's just anatomy. If the prostate's too big, there's no way they can radiate the prostate and miss the bladder and miss the rectum and all the side effects that go with that. So if the prostate's smaller,
thank you.
Simple anatomy, yeah. In addition, the larger the prostate, the more radiation they're going to have to give. So a smaller prostate is better for side effects, and probably ask them that. Ask them if it means less radiation. In addition, if you're on hormone therapy, the next thing I would ask him is, when can I take a PSA again? Can I do one before radiation? Because it would be interesting to know how far your PSA fell just on hormone therapy alone. There's a good chance it could fall to 0 just on hormone therapy alone, or close to 0. So that is suggestive and would raise a question for me. Can I wait to do radiation? I'm on treatment right now anyway.
Thank you.
Jan?
I didn't want to capitalize on this conversation, but interestingly, my PSA is 2.
Your PSA is 2, but you're in the intermediate risk. So
that's correct. The biopsy. They did a biopsy, and I won't go into all the detail now, but yes, I'm definitely I'm a stage 3/4.
Do you mean a Gleason?
Which is 7.
Do you mean a Gleason 3 + 4 = 7?
Oh, I'm sorry, Gleason. Thank you.
So that would be
so yeah, I did
grade group 3. Yeah.
So the doctor had given me the on the NCCN Guidelines thing, intermediate. So I didn't want to capitalize on this, but what isn't clear that might be of general interest to people
Yes.
is whether having if I go on if I go on hormone treatment,
Yes.
does that make me any more susceptible to this virus?
Great question. And let me answer one question first, and then I'm going to hand that over to Joel. And again, we can't give you medical advice, but we can tell you some possibilities. The quick answer is probably not, but I'll let Joel explain. Let me go back to, your comment about not spending much time on your situation. We've got plenty of time. But the great thing about this, Jerry, is while we're doing this, everybody's learning from your situation. It helps them. So it's fine. What we're doing is taking.
No, I'm happy to do it.
Yeah. So
I'm happy to do it.
Okay.
And there is no confidentiality. I don't care about that.
Okay.
But I just didn't want to capitalize on the conversation.
Okay, we've got plenty of time. So, Joel, you want to comment?
Yeah, absolutely. So that's a really interesting question. And a week and a half, 2 weeks ago, I really kind of assumed that hormone therapy depresses your immune system. But I reached out to an immunologist who specializes, a prostate cancer immunologist named Dr. Chuck Drake, who is going to be doing next, I think Friday, is going to be doing a webinar with us about immunology in prostate cancer. So you may want to, if you're interested.
A week from Friday. Yeah.
A week from Friday. I'm sorry. Yeah, a week from Friday.
Yeah.
And I asked him a very specific question. About does hormone therapy in any way affect the overall immune system? And he gave me an answer that surprised me. And he said, well, there's not been any research specific to people, to human beings, but within animal models, hormone therapy actually seems to enhance the immune system. And I was a little caught about surprised. I had originally asked him about a specific hormone therapy drug, and he answered back to me ADT in general. So I reached back out to him and said, well, what about this drug? Because it's one of the ADT drugs. It's called Casodex. And his response, that all sorts of ADT within the animal models seems to enhance the immune system. Now, what's important in that answer is the word seems.
Yes.
So there's evidence, it's not proof. And secondly, animal models.
Sure.
We're not animals. We often, we can respond differently. So the best information we have is there seems to be an increase in the immune system within the animal model. And that's the best answer anybody can give you.
Yeah, so that gives you a great question to ask your doctor. I'm hearing that maybe is a good word to throw in there, but we don't have like proof on everything, but there's always just a myriad of evidence out there that's developing, and in the right situation, it does create the right question so that you can make a treatment decision, or anyone can. So these are unusual times with the pandemic, and so everybody's wondering about their immune system. I agree.
Hi, Jan.
Can I make a general comment?
Yes, Jerry, and then Bernard, I'll get to you. Yeah.
I'll stop.
Go ahead, Jerry.
I was told I met with a surgeon prior to coming down about radical prostatectomy.
Yes.
And he made a comment to me that I thought was a little surprising. I asked him, is going to Florida for 3 or 4 months a big deal? He said, no, because prostate cancer is very slow growing. Now, I don't know whether he was talking about mine or in general.
So with your prostate cancer, if your Gleason was 4+3, Gleason score measures aggressiveness, or
3+4.
3+4. Thank you. Gleason score measures aggressiveness.
3+4.
So that's your measure. So you were grade group 2. Are you sure you're not favorable intermediate? You might be favorable intermediate.
No, I'm looking at the report. He circled intermediate, unfavorable, intermediate is what the the urologist had circled.
Gotcha.
So, but my real question, my real question is,
yes.
how much risk is there in putting off any treatment because I'm a candidate for either?
So let me comment on what the Gleason score measures to help you. It's, in simple terms, this Gleason score,
Okay.
the 3 here is the lowest number that you can have. So that means it's the least aggressive prostate cancer you can have. There is no 2 and there is no 1 in the Gleason score. I'm not talking about the grade group. In the Gleason score, it starts at 3 plus 3. So it starts at 6, which just sounds funny. It seems like it started at 1. It doesn't. It starts at 6. So in simple terms, the Gleason 3 on your prostate cancer pathology is the least aggressive prostate cancer possible, and it's the kind of prostate cancer that doctors don't worry about, for lack of a better term. It's the type of prostate cancer that Dr. Klotz has documented does not metastasize. It's the type of prostate cancer that doctors also use the word indolent, and the recommendations are clear that active surveillance is either recommended or preferred. That's Gleason grade 3. Now, there's 2 numbers in your score. Now, the Gleason grade 4 is the aggressive component. So if your 4 is the first number, it means you have more 4 than 3. If your 4 is the second number, it means you have more 3 than 4. So if you have a Gleason 7, you have a combination of the 2. Okay, you've got the non-aggressive stuff that they recommend active surveillance for, and you've got some aggressive component that they recommend treatment for. So you're a mix.
Thank you.
You're welcome. Let me make a comment on hormone therapy. That's something you could just have locally. And the recommendations right now are leaning towards, okay, so the injections come in 1 month, 3 month, 4 month, and 6 month. Okay, there's different strengths, different lengths of injection. I probably will always argue that doing a shorter shot the first time is often more gentle on the body, where doing a big shot the first time can be really hard on a man or a woman. So the recommendations right now are to try to have less visits, but I'm still going to argue that a 1 month shot might be preferable. So, but that's a question that you can ask.
Thank you.
1 month, 3 month, 4 month, or 6 month.
Thank you. I was not aware of that.
Yeah.
Let me expand, if I might, on why some recommendations now are suggesting a longer shot as opposed to a shorter shot. And that is the overall goal in dealing with the coronavirus is to have less exposures, interpersonal exposures, and you do need to go. There's 2 ways to administer hormone therapies. One is there is an oral medication, but that's not nearly as complete as having the injection along with the oral medication. And the injection involves you're going and having an interaction, usually with a nurse who's going to administer it. It could be the doctor. And the overall goal on the new guidelines responsive to the virus would be to give a longer injection to eliminate that. And everything is a risk and a reward.
Right.
And so, I just want to clarify that, make sure that, there are trade-offs, as Jan has said, and there are positives and negatives to each of the options.
Yeah. And there's a shot called
Thank you.
Firmagon or Degarelix that does not have a flare reaction, but let's get into that later. But Jerry, we can talk later. But at least some questions you can.
Thank you. I'll stop.
Yeah.
Jan, may I?
Go ahead, Bernard.
I'm sorry I can't go into the chat box from my cell phone, so I apologize for jumping in over the microphone.
Yeah.
One of Jerry's last comments was, and I'm a stickler for words here lately. I don't know why, but it said, and we hear it generally, prostate cancer is slow growing, not when it's outside the prostate.
Well, Bernard, that's why he explained his Gleason score.
Right.
So he could
in general, the communities are going around. Men are under the impression that the best, if you're going to have prostate cancer, the best one to have is prostate because it's slow growing. And the answer is no.
So
It's slow growing in the prostate.
Some are slow growing, some are not. And what we're learning here is there's 6 different categories. So you cannot really make the case that high or very high is slow growing, right? But you can make the case that low and very low risk are slow growing, and that intermediate is in between. So there's
the words that
not all slow
that
growing,
go
not all fast growing.
Right. But the words that go along with the literature in prostate cancer are death rate and progression and stuff like that. So for us to sit back and for anyone to sit back and under the impression and making a diagnosis decision that it's slow growing or not is not a good calculated risk, in my opinion.
It's too broad of a generalized statement. We're breaking it down today. That's what we're doing.
Right.
Yeah.
Okay.
So,
go ahead.
Bernard, I was going to say, I too, my skin crawls a little bit when people say, "Oh, you have the good cancer." There is no such thing as a good cancer. We're 100% on board with that, with you. And there are some men whose prostate cancer grows more quickly and more aggressively than others. However, I'm not sure that whether it's out of the capsule or not, or have metastasized is necessarily, and I don't really know the answer related to how quickly it grows. I'm 13 years, and and I said I've been metastatic for 13 years. I know guys that are metastatic for 18 and 20 and 22 years. I think a lot of it depends upon the nature or the underlying genetics of your cancer. Is my guess, and it's a guess.
Yes.
But yes, if you have cancer, you need to deal with it seriously, whether it's a slow-growing cancer or a faster-growing cancer, because you need to learn and understand your cancer. And that's one of the things that we're trying to do today, is to help you maybe better understand your cancer so you can make better decisions. And I actually take the attitude that even active surveillance for those people who qualify, that's a method of treatment. You don't just sit there and have it. You do things. There's a regime that you should go through, and that's, in my opinion, every bit of treatment as going off and having chemotherapy or any of the drugs, or surgery or radiation.
Well, it's as much of a choice. Yeah. Right.
Yeah, but it's a treatment. So
it's a definite choice.
So the answer is some prostate cancers are slower growing than others, just as there are breast cancers that grow more quickly than others. That's really true. And so I think it's a good point, though. We need to treat cancer seriously, whatever the rating is.
Right.
Jan, for the sake of the size of the prostate, for the gentleman who was speaking earlier, and maybe this will help a little bit. And now this is 4 years ago. 46.1 grams, 4.2 by 3.5 by 3.0, 40% of the gland tumor. In general terms.
What was your question, Bernard? What was your question?
Well, you had asked the gentleman what his prostate size was.
Right.
And I've heard you ask that repeatedly several times. It's an important question. So as something to go by, if a prostate was 46.1 grams and it was 4.2 by 3.5 by 3.0 centimeters, in prostate cancer world, where does that prostate, that size, fit in? Now, mind you, let me back that up.
I don't know how to do those formulations. A radiologist or urologist needs to do that. But what I would do instead is look for the 46.1 grams that you just mentioned, which could also be 46.1 cc or 46.1 milliliters on one of the imaging reports that I referred to earlier, which is MRI or ultrasound. And the other option is I would ask my urologist what he estimated on digital rectal exam. That's how you get prostate size. But I don't want to start, I want to be careful about suggesting how to do a formula. I think that's above our pay grade.
I didn't want to get into formula. I was just trying to get an idea of a size to give everybody in general what a size of a tumor, a stage 3 tumor was, in other words.
Size of prostate and size of tumor, they're two different things, right?
Well, the notes in the pathology says 40% of the gland was tumor.
Yeah, that's a different issue, though.
Right.
Yeah, so I want to get on to other people before they click off and see if they have personal questions about their situation. One person typed in that they're intermediate unfavorable. Another person typed in that they're high risk. So do either of you guys have some questions that you'd like to ask?
This is Ray. I just want to have a
Hi,
comment,
Ray.
maybe where
Yeah,
I'm at. Yeah,
you
I
bet.
was diagnosed with the prostate cancer probably last September, October timeframe.
Okay.
Since then, I've gone through a 4K MRI biopsy, and basically, I was driving the stuff that with the doctor or the PA that I had. So just recently, in the last month, I've switched now to the UF Florida in Gainesville.
Yep.
And after reviewing with them, I'm going to have a consultation tomorrow, actually, on the phone instead of in person because of the current situation. But I've got a very large prostate, have had it for many years,
Do
and
you
they
know the
just
number?
discovered
Do you know the number
on,
size?
yeah, 114.
114 grams?
Right.
There we go. Now that's really
Yeah.
specific and very important.
Right.
If someone was,
And I've had a PSA. My PSA back in 1996 was 1. And in 2015, it crept up to 3.8. The last number I had, which was interesting, this last year when I was diagnosed, it was about 8.5. Then it went up to 8.8 in a couple of months. It went up to 9.1 last summer. And then I just had it PSA checked at my recent one, and it's down to 8.3 now. So, but anyway, after
yeah,
reviewing with the ones in Florida, I had a meeting with one of the doctors there. In fact, he was a presenter at one of the seminars here just recently that they had in the villages. Anyway, after that, I'm still at the intermediate and favorable, but I've got a meeting tomorrow to explore the proton treatments they've got and look at a clinical study or possibly having the see if I'm a candidate for that.
Here's the issue: that prostate is very large.
Right.
My concern is there's just no way they're going to. So let me back up a little bit.
Okay.
I'm assuming that if you were diagnosed last September, October, do you have a Gleason 6?
I've got it's primarily in one section of the prostate, and when the biopsy was done, there's
What is the Gleason score?
The Gleason score they had 5 because they were able to target that area. So the right side was all benign, and the bottom and the left top corner, that's where the lesion was. 2 of the scores were 4.3, and 3 of the scores were 3.4 or 3 plus 4.
Gotcha. So that puts you in unfavorable intermediate risk, correct?
Correct.
Okay. Have you started any treatment at all? Has anyone suggested?
Not yet. No, I just switched over to UF because I was more comfortable with the doctors there that I've talked to so far.
So the first treatment, if you're going to consider radiation, is definitely going to be hormone therapy to reduce that size of that prostate. Mm-hmm. I mean, I'm almost positive about that. Mm-hmm. I can go back and research. I have a video from the head of the Astro organization several years ago that said the largest prostate that will radiate is 60 cc. Now it's probably a little bit outdated, but it gives you an idea that 114. I don't think.
Yeah, well, that's one of the questions I'll have tomorrow when I talk to the doctor, because I haven't had the chance to talk to a oncologist yet. This will be my first. And I've got some questions. That was one of them.
So the first treatment is likely hormone therapy then. I would focus on that. And the same questions we talked about with Jerry.
Right.
How about a 1-month shot? What you'll find is if you're having any urinary symptoms, they'll probably get better, improve over time. And again, it'll drop your PSA very low and possibly close to 0, maybe. So what it means is you're on treatment. So I'm never quite sure. Honestly, a radiation oncologist needs to weigh in on this. But if there's a rush to radiation, especially if you're waiting for the prostate to get smaller and your PSA drops because of hormone therapy and you're on treatment, So
Yeah.
I don't know, but I would ask.
Well, right now we're not rushing into any right now because of my experience the last couple of years at the prostate support group here,
Yeah.
and then I've been on the webinar when we had the not only the webinar but when we had the discussion back here in person on the hormone therapy and stuff. So
Yeah.
I was kind of aware of some of that stuff, and because of my large prostate and stuff, the BPH and stuff. So
Yes.
I've gone through a lot of that stuff. I feel comfortable now, at least talking to the people and understanding where I'm at and what probably should happen. And
Yeah.
that's why when I switched over to UF, they seem to have a lot more resources there than maybe the person I was talking to over here. So I'm comfortable right now.
I would be really concerned about the size of the prostate. They even use
Right.
something called Spacer, which helps to protect the rectum from radiation, but it doesn't protect the
Right.
bladder. You can end up
Right.
with, a lot of problems, blood in the urine,
Yeah.
a lot of stuff. So let me ask you this. How's your overall health and age?
Age is 78. Over health is excellent.
Got it. Okay. I was going to talk about surgery, but just being age 78 kind of, makes your risks with surgery a little bit higher for things like, cardiovascular issues. But one thing I will mention is for men who have a very enlarged prostate, although surgery can really, create problems with incontinence and sexual function, one thing it does is it'll often just relieve those urinary symptoms by removing the prostate. So just to keep that clear, and if, I was to consider that, I would definitely look for an artist. So somebody like Dr. Patel in Celebration, something like that. But at age 78, your risk of complications is considerably high. So those are just some things to think about. The size of the prostate with radiation would be my primary issue. I'd be talking about, asking about, considering hormone therapy. And if it was me, I would be asking them to remeasure that prostate before they started radiation. I'd want to make sure it got down smaller.
Right.
Before they go in there. Yeah.
Right.
Got it. Those would be the questions I'd ask. Joel, you have anything to add to that?
No, I don't. I mean, I agree that from my understanding that prostate gland is too large to radiate, and it will probably have to be dropped. And and given again the fact that you may want to limit your actual exposure to people in today's world, maybe continuing the ADT and delaying the radiation might be something worth exploring with the doctor. They're probably going to raise it to you anyway. I wouldn't be surprised. So I think that's a good approach. And it's a lot of surgeons for a man of 78 will not do the surgery. I'm sure you can find someone who would, but it's good reason. And I think probably you're on the right course given your age.
Okay, thanks.
Yeah. So Bob, did you want to mention anything about your situation?
Yeah, can you hear me okay? I'm on my phone.
Yes, I can. Yes.
Hold on 1 second. I have to turn down the speaker.
Bob, can you see the slide?
I've had this since 2013.
Okay.
Where I had elevated, and I had MRIs, and I also had biopsies that were negative multiple times, and that was 7 years ago. And in September of last year, my PSA all along it's been going up. But as far as the category, I'm high risk because of my PSA and because of my Gleason score. But my prostate's not big. It calculates 34 cc's and then 24 grams on ultrasound.
Okay.
Which I'm not exactly sure.
Yeah.
I don't know what a PIRADS 3 lesion means. That's what they see on MRI.
I can explain that to you if that's helpful. We can come back to it, but
yes.
Yeah. So let me pull up a diagram here. But a PIRADS score is tells you on a grade 1 through 5 how likely it is that you have Gleason score that's higher than 6. So how likely it is that you have a Gleason 7, 8, 9, or 10. pi rad of 3, which is right in the middle, means basically they don't know. They call it unequivocal. Excuse me, I'm trying to minimize this so I can get the pi rad scores. And so some experts I know would say that a pi rad of 3 indicates a need for biopsy. Some might say it doesn't. But basically it means it's right in the middle. They kind of don't know if you have Gleason 7, 8, 9, or 10 in that spot.
Okay. But over the years, I'm a T1C, but I've had, like I said, 6 different biopsies, and one of them saturation was 22 cores, and a couple MRI guided, and they were all benign. They didn't find anything. With the last one, out of 14 cores, one core had 2 millimeters out of a 13 millimeter core that had a Gleason of 4. They kind of make,
you mean a Gleason of 4 plus 3, 3 plus 4?
Plus 4.
Oh, a Gleason of 8. 4 plus 4 equals 8.
Yes, I'm sorry. Yeah.
Got it. Okay.
Yes. I'm sorry.
Yeah, that's okay.
Which I kind of, don't understand
because you at high risk. Yeah.
Well, my PSA is at 26.
Oh, got it.
Which also puts.
Yeah. Okay.
And right now, I'm really struggling with. In fact, I wanted to make this decision last week. I don't want it to go on anymore, because it's been a while. Well, it was mid-February where I finally had the positive biopsy. But anyway, I'm just struggling between surgery or EBRT, seeds, and
yes.
ADT.
Okay, so your prostate size is suggestive that, it's not too big for radiation. So that's favorable for radiation. I would argue there's benefits and risks to both. One of the benefits of surgery is that any cancer removed can never come back, and then you get your whole pathology. But one of the downsides is it's much more likely for you to wrestle with incontinence and even some sexual function issues. With radiation, it's likely that you wouldn't have any incontinence issues, although they may develop later, like 5 or 10 years down the line. And it's highly unlikely that you'd have any sexual function issues, although they may occur later down the line. So that's a little bit of side effect explanation. If you were to choose surgery, I would argue heavily to go to an artist like Dr. Patel, P-A-T-E-L, in Celebration. That makes a world of difference. This surgery is very unique. The anatomy is very challenging. It's not like breast cancer surgery or, lung cancer surgery. It's very different anatomy-wise, very tricky. So choose an artist. Every urologist is a surgeon. That doesn't mean they're all excellent at it. So that being said, what are some of your thoughts on what matters to you?
Well, what matters to me, honestly, is to be cured. And when I look at like prostatecancerfree.org, and they've got all the charts and so forth, and it shows recurrence rate is much better. It's much more favorable with the EBRT, seeds, and ADT than the surgery, across all those groups. But recurrence rate and survival, total survival, I guess, are 2 different things. So that's what I don't understand. Because I understand I guess if you have the radical prostatectomy, you can always go back and get EBRT or some type of radiation.
Right.
But I don't know what you do anyway if it recurs.
Joel, you want to comment?
Yeah, I will, and I also want to raise another issue.
Okay.
But as far as if you remove the gland surgically, a reoccurrence will come from a number of different ways. One possibility would be that there was some prostate tissue left behind in the surgery, And so one would argue that that, remains, the cancer would then remain in the prostate gland. It's just there was tissue left behind. The other possibility is that there had been a release of cells prior to the surgical intervention, and those cells have, now started to find a place to live and grow. And that would be either locally advanced, in other words, prostate cancer that is within the prostate bed, but not the prostate gland itself, or perhaps from a metastatic spread. And that's really where reoccurrences, can come from: leftover tissue, locally advanced, or metastatic. If it's metastatic, and you use that C word, which I don't like to use, but if you use the C word, then yes, that there's no way to obtain a cure. If it's removed from the gland, and the gland is the only place that it is, then the answer is yes, you shouldn't have to deal with the cancer again. So I don't know whether that answers that question. I actually have a question that I would ask the doctors. You've had a lot of different biopsies now, and they've all been negative. It sounds like you've had massive numbers of biopsies, and they've only found, if I remember what you said, one place where there was a very small amount of cancer. Is that correct?
Correct.
So
Correct.
My question is, and yet you have a PSA. You said it was over 20, correct?
26.
So 26. So that's and your gland isn't that large. It's not like an oversized large. So the question that I would want to ask the doctor, given what may be a minuscule amount of cancer as far as in my gland, and a PSA which is higher than one would expect with that kind of one small piece of cancer, is there something else going on that we should look at, examine, or think about? And that's a question that I have for you. And I think that a medical oncologist who specializes in prostate cancer is definitely a person that you may want to touch base with. I don't know what you think about that, Jan.
Yeah, my question would be, where's the rest of the PSA?
Right, exactly, because that little piece of cancer that they found, could it generate that kind of PSA? Yeah, I think it's highly unusual, though.
Highly unusual. So, Bob, after remind me again, your Gleason score is 4 + 4 = 8?
Yes.
Okay.
Yeah, but there was
Did they order
really
a bone scan or a CT scan?
Yes, I had both, and everything was good. It was okay.
It was negative. That might lean me towards the hormone therapy plus radiation just because of that. Because with surgery, the scalpel can only remove, the prostate and the seminal vesicles and then samples of lymph nodes, whereas the radiation can radiate the prostate plus the surrounding tissue plus the prostate bed and into some lymph nodes. So it might lean me in that direction.
Okay.
Again, it's only
and I just
question.
Yeah.
Now,
no, not really. It's not a question that can be answered probably. It's just that I like, again, the incontinence really bothers me and so forth with the surgery, but but the long-term survival is where I'm most interested in, honestly. So
long-term survival is different than cure. Just because you don't get cured doesn't mean it's life-threatening. Because there's this weird reality that you can actually live with a little bit of cancer. Nobody really says that well. But that's what Joel and I are telling you with our stories. It's when you stay engaged and when you do treatment and you stay on treatment that works for you without having the side effects too bad, even if the cancer did come back, that does not make it life-threatening necessarily. There's a middle road. That makes sense?
Yeah, makes sense.
I also want for 13 years. Yeah.
I also want to talk about the concept of incontinence. There is no standard way to measure incontinence, and so when we use the word incontinence, the question is, what do we mean? So it is possible that incontinence could mean that you have absolutely no urinary control at all, and you just go around walking around leaking everything, and you can't hold. And then there are little drips. And the question is, we don't, what does incontinence mean? The vast majority of men, and they're, don't have the kind of incontinence where they have no control. So it's not uncommon for a person to wear a pad, perhaps, and they have a little dribble. But that's going to happen to us as we age anyway, in reality. So could you suffer incontinence in the sense that you'd have to wear a diaper? Yes. That's a minority of men. So I think there are things, that you just don't assume that incontinence, if you do have any sort of effect, that it means that you're going to have no urinary control at all, because it does not necessarily mean that. Matter of fact, the vast majority of people, that's not what it means.
But incontinence is much more likely with surgery and much less likely with radiation. I think that's really important. Yeah.
Yes.
Hey,
yes.
hey, Jan.
Yeah.
May I a bullet note and redirect me? Radiation, surgery, no. Surgery, radiation, yes. My question is, my understanding is once we decide to take treatment and go with the radiation option and not surgery, some surgeons are a little bit reluctant to come back and do surgery on someone who has been radiated.
I hear that a lot. Let me comment on that. Surgery after radiation or after cryotherapy or after they've done something to treat the prostate is really, really hard on the patient. What I mean by that is the tissue is changed, and it's almost impossible for the surgeon to do anything gently. So you are going to have problems with both incontinence and sexual dysfunction. So it's not always a great option. So, but that doesn't mean there aren't other options. That's the problem. It's not like surgery and radiation are the only two things. They're not.
Okay, and so for the gentleman who just spoke, because what I find is we put our dignity before our life in some cases. My erection, my incontinence, okay, and it's a shock, yes. Coming from a 57-year-old 4 years ago with a C3 tumor, no, we can't find none in the body, and the labs and everything suggested it was organ confined, but at surgery it was not. So the resection was wide, everything on the right was removed, and then radiation and hormone meds. My point is this: 3 years later, I was in pads for 29 months, big thick pads that come 52 to a pack. 7 months of that was pads and diapers. October 31st of 2018, on the 19th, I sat with Dr. Young at UF Health, and on the 31st, I had 2 balloon PROACT incontinence implants embedded in me, and I have not worn a pad or a diaper since.
Do you know if that was an artificial sphincter or a sling?
No, neither. It's 2 little balloons. They look like little tadpoles. They go up through your perineum. They put them right up against your bladder and alongside your urethra, and your sit bones eventually work them. The point is this.
You want to comment on that?
Yeah, I actually, first, that's a relatively new treatment in the United States. It's been used in Europe. It's called, I think it's PROACT, I believe.
Yes.
And yeah, it's really, it's new in the United States. They have not done an extraordinary number of them, and the few people I know who have had them have actually been very happy with them. So it's neither a sphincter or
no,
or a sling. And I think we're going to be increasingly hearing more about it. And I'm glad you brought that up. Thank you, Bernard.
It was approved. It was approved. Yes.
I want to ask you who your surgeon was. Did you say Dr. Young?
Dr. Lawrence Young at the Urology Oncology Department at UF Health at the Davis Cancer Center, who worked with my surgeon, Dr. Lee Ming Soo, who is as qualified as Dr. Patel as well, in removing the prostate. He's done many of them. But my point was this: that what we were worried about was that with radiation, the implants wouldn't take. We were worried about erosion issues, whether erosion to the urethra or to the balloons.
Okay.
I went in 4 hours through the surgery treatment, I went from 3 pads a day to 0 for 6 weeks. Then it came back. I went back. I called him on a Friday night. He told me to come in Monday morning. We looked at, we did a cystoscopy. You could see the balloons and you could see the gap between the balloons and urethra. We decided to add a half cc more, which you do through some titanium ports that sit in the testicles. And in 20 minutes, I've never worn a pad or a shield since.
How many?
That was October,
yeah,
January of 2019.
Very good. Okay,
So,
that's really interesting.
like Joe said in the beginning, there's medicine ahead of us. It's just we need to be engaged with our doctors, okay?
Yes.
We also need to know about the ADTs and all the things that come with it before we make a decision. And we should talk to people who have had those treatments. The doctors don't know.
Right.
I wish I had the hindsight of 4 years ago of what I know now. I don't know that I would have changed my treatment, but it would have helped a lot more had I had some more knowledge, okay? Because my point is this. You can have all the imaging. In June of 2016, I had a PET scan. They discontinued the NAF18. I had a biopsy, and at that point, everybody was said that it was organ confined. Had I gone with that, my treatment and diagnosis might have changed. I said no, the numbers are too high, PSA at 134, Gleason 7, let's take it out. And when we took it out, we found out it was not organ confined. So these decisions we make, they're hard to make because until we get in there and see what's in there, nobody knows.
Bob, how you doing? You have any more questions?
I'm just listening, so
Okay.
it's interesting. Yeah.
Yeah, this is Bernard. He's one of the facilitators up in the Villages support group, and he's got a long story with prostate cancer. So, yeah. But you can hear his passion for working with his doctor and staying involved. I would really back that up for sure.
Okay.
In the Prostate Cancer Foundation patient guide, I just saw it last week. It says that testosterone bicalutamide works on the testosterone. And Joel, here's your big word, in the prostate cancer cells. So that's telling us that testosterone is in the cancer cell.
Right.
So
not outside of it. It's not blocking it because it's in it already.
It's both. Yeah, be careful about it's
yeah,
one place.
I think Jan's point is testosterone comes both from what your body makes, which is outside, and the cancer cells do eventually, as they mutate, learn how to make their own testosterone. And that's why some of the more advanced drugs that we use once ADT has failed will actually stop the production from within the cell. But primary first-line hormone therapy, including bicalutamide, as you mentioned, Bernard, does not do anything to treat the testosterone, as you said, that's inside. But that actually, in most cases, until the cancer advances and we end up becoming castrate resistant, in other words, no longer responding to hormone therapy, that testosterone is not being manufactured. That's something that happens as the cancer progresses.
Hey, Joel, something caught my attention, and then I'm signing off here. I'll leave you guys alone. It said also in the same book on page 67 that PCF funded a test to indicate whether prostate cancer may be fueled by hormones outside the testes.
Okay, I'm not familiar with the test, but we do know that prostate cancer does get fueled by hormones that are generated outside of the cancer cell. From 90% of your testosterone comes from the testes, and then the rest comes from other places, including eventually within the cancer cell itself. So I'm not quite sure what the question there is.
Like Jan had indicated, the genetic testings to find out the aggressiveness of cancers and to see the treatments that would be proposed to you would benefit you. and one of them now is the ARV7. And I'm getting way ahead here, but
that's
I want to
different.
I want to mention it so that the guys listening, as you're formulating and you're going through this misery and despair, take these bullet notes and look into these things. They might answer the questions you're having a problem with as far as what to do for your treatment.
Yeah, ARV7 is for men on hormone therapy, so that in advanced, so that's a little bit different. But you're right, stay engaged, but know what type of prostate cancer you have, so you're researching something that applies to your type of prostate cancer, not someone else's. So I hope that we help people with that today. So are there any other questions? We've still got 5 people on. Happy to answer questions.
So, Jan, if we're coming to the end, I just want to reconfirm that anyone who spoke, that no one would have a problem with making this public, because I think this conversation could be very helpful if we can have it out in the public that people could listen to. But again, if somebody is uncomfortable, for those people who spoke, we would never do that. So if you're uncomfortable, either let us know now or send Jan or myself an email and just let us know, please.
So let me ask the 2 people that are on. Bob, how do you feel about your first name being mentioned in a video like this?
If it's just my first name, I'm okay with it.
Okay, Bernard?
I'm good with anything. I'm an open book.
Those are the 2 that are still on. I think everybody else, I'm not sure.
Yeah, I think the only one else spoke was Jerry, and I think he said he was fine with it.
And Jerry is still here.
Oh, is he? Oh, good. Jerry, you spoke.
You okay?
I say Jerry is still here. You can use any information that I have.
Okay.
No problem at all.
And the last one was Ray, and he's not here. He signed off, so I can check with him.
Yeah, that's great.
Okay. All right. Well, I hope that you guys you're getting the message to understand that your prostate cancer is different. Read your medical records, circle the big words, call me if I can help, email Joel, and stay engaged in your care. And better questions you ask your doctor, the better answers you're going to get.
Jan, Joel, thank you very much. I appreciate everything you do.
Thank you.
You're welcome.
And is anybody want to give me a call at any time when they're in the jungle? Feel free. I'm here for them.
And also, if anybody's in the villages, they should consider going to the support group there. It's probably the best support group, better than the ones that I run. So I would highly recommend it.
First Wednesday of the month, 7:00 p.m. webinar, probably.
Well, we're doing the meetings with the same go-to meeting as well for now. So everybody, thank you.
Sounds good. Thank you. Bye. I'm going to sign off.